Hello, good evening, and good afternoon to everyone, wherever you are in the world. Thank you for joining me again for another one of our insightful sessions with another COVID expert, Dr. Ellapen Rapiti from South Africa. Now, if you remember, Dr. Shetty is also South Africa. So, remarkably, they seem to be producing these remarkable clinicians who are able to understand disease and try and adjust themselves to work with it. More than ever, I want to highlight that we are facing a global crisis. Well, actually, not all of the world is facing this. It's highly vaccinated regions seem to be having an ongoing circulation of this virus. We need solutions, we need creative thinking. And this is why I'm so interested in speaking with frontline people who manage their way through the pandemic and who now will have remarkable insights that are important for all of us to learn. So, without further ado, let me bring on Dr. Robert Ellapen Rapiti. So, Robert, I think we'll stick with Robert. Can
All
you
right.
just introduce yourself to the audience?
Hi, afternoon, good evening to you, Philip, and thank you for having me on and to your viewers. I'm a family physician. I've been in practice for over 45 years. I've worked 3 years in a hospital as a registrar. I've got a wide experience in all disciplines of medicine, I think, that are relevant. It makes me highly suitable for, general practice. And my special interest today talking to you is about COVID and my success stories and how I think I've got it right when the world got it wrong, because I've seen over 3,000 patients and I've had a 99.97% success. Just to tweak the interest of your viewers, that I've got patients that four of them that had 35% oxygen. Two of them discharged themselves from highfalutin teaching hospitals and private hospitals, came to my rooms. I treated them as outpatients. My point here is that I could treat patients as an outpatient. There was no need for sophisticated technology, and I used just clinical tools. I'm through the process of this meeting. We're going to talk about it. I'm writing a book, and the title of the book is "No One Should Die from COVID." I've been an arch activist. I put out videos of my success stories. Very, should you say? Would you say, naively thinking the world would be excited? Oh, there's a doctor saving people, only to discover Facebook pulled down all my videos to say that you're against community interest because you're saving people. That was the bottom line. The same thing happened with YouTube. And fortunately, I've found Telegram, and I managed to get it across to people. And I'm pleased to hear throughout the world, people have picked up on my videos and have thanked me from all over the world for I don't call it a protocol, but my approach, because I do not work as protocols. This is what the medical establishment does. Everybody is an individual as far as I'm concerned, and my treatment is tailor-made. And I'm going to today show to you how I've debunked all the narrative of the people right from the top academic, and I've challenged them in court as well. I'm an expert witness in court, and for once I can say an expert is not someone with degrees. An expert is someone with knowledge that can make a difference. Well, I think
Wonderful.
I've said,
Yeah, and
yeah,
listen, Robert. Yes, so this is important because I think one of the lessons that we've learned in the pandemic is that
yeah,
you have all kinds of experts, and when
yes,
we think even about clinical medicine, you will have, gastroenterologists, you have respiratory specialists, you have cardiologists, there are all kinds of different specialties. One of the problems has been is that many people perceived that COVID would fit under a specialty. And part of the challenge has been that it doesn't. It is not a specialized disease in that, even though it presented with respiratory complications initially, it was not a pulmonary disease. And it's that kind of issue. And so many people are saying, well, who is an expert in terms of COVID-19? Is it therefore the immunologist? Is it the virologist? Is it the respiratory? What are your thoughts on that?
Well, I think COVID is a multifaceted disease, and I think I would put myself as an expert because, right down from clinical medicine, I also do mental health. I hate the word psychiatry. I've been one of the few doctors who said that antidepressants don't work because people come with a variety of clinical symptoms from head to toe. You've got to have an open eye for differential diagnosis. I've had so many patients presenting to me, for example, with anxiety and panic disorders and asthma coming to, oh, doctor, I think I've got COVID. And you had to have your eye on the ball and know exactly, and you had to think and act very fast. I mean, I had people breathless, and I would put my arm around. I could see with my years of experience, this was a panic attack. And they would just wake up and say, "Oh, thank you, doctor. I'm feeling relieved." So, I don't think one person could be consider them an expert in this field. I mean, you could be an expert in the laboratory. What could you do in the rooms? Dr. Chetty and I were seeing them in the front line. If ever there's a pandemic again, they got to go to guys like Dr. Chetty and myself and say, guys, what are the signs? What are the symptoms? It doesn't matter if you see the mutations 100 times under your microscope. Does it translate into any clinical form? No, you cannot say that. But I can tell you firsthand, I knew when we talk about Delta strain that the narrative coming from the FLCs and even from my good colleague Dr. Chetty 8 Day was wrong. And I'll show to you what I did. By then I had known the pathogenesis because when we go into the history of how I got involved with COVID, I said to myself, I've got a bit of ADD. I'm a guy who likes to challenge new things. I said, this is a war against a virus, and we the soldiers. When they said don't go to work, I said, hell, man, I'm 72. Soldiers don't die in the bunkers, they go in the battlefield. And I said to myself, whilst I was lying with a heart attack, I'm going to get back to work and I'm going to knock this disease. I'm going to find a solution. And it's amazing. I believe in the power of affirmations and positive thinking. And I can tell you it was a eureka moment for me when it hit Delta strain. Delta strain by far was the worst. I've dealt with the wild type, the alpha strain, and the beta strain. They were easy peasy, they were self limiting, and I can say categorically those were 99.95% didn't need intervention. I did very little other than reassure people. It was in the Delta strain I came into my helm. I really saw the thing, and people were streaming to me from all over South Africa. And Philip, I was treating people from overseas. I became so adept at it. I could treat you over the telephone, giving me your symptoms. And we will talk about my 8 symptoms, clinical symptoms.
Yeah,
And I
this is
think
what
they
I'm
should.
interested in here now. So yeah, so for apologize to the audience. This is important clinical discussion, and it is very valuable to listen and to reflect carefully and to tie the clinical presentation with the research. And so
Yeah.
this is now let's dig into that a little bit, Robert. Let's talk about what you saw in terms of the main clinical presentation in Delta. And just to explain to people, the reason we're doing this now is because the more we have an understanding of the clinical presentation with the different variants, the better we'll be able to handle where we are today. So
Yeah.
let's just dig through. What was it that you were seeing with Delta?
Okay. I have the slide, but there's so many of them. There's
Yeah,
60
you
slides.
tell me what number you think.
I don't know if it's 18. I would think
Okay,
it's
I'll
probably.
bring it up for you. It's about it,
Yeah,
17, 18. Yeah,
you'll
okay.
see
Mm-hmm.
a thing called there's a table with all these different symptoms. Is there a table with all the symptoms? I'm not sure if it's
Oh,
18,
sorry, I didn't
23.
add it to the screen. Sorry, I thought I had. There we go. With all the symptoms, which one?
Just go down, 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 down. Yeah, it's quite a few.
This one here.
Yeah, that's it. That's it.
Yes,
Let
that's
me
it.
tell you what
Okay.
happened. Paul Marrick, I have the greatest respect for Paul Marrick. Paul and I get along so well. And he was once in a talk said, you wait 8 days because by that time the virus then goes into a pneumonia stage.
Mm,
And that is when, and you don't use your steroids before the 8th day. What I was seeing, I was seeing a whole lot of the alpha type, and they were really nothing more than a common flu. As far
Mm-hmm.
as I'm concerned, the wild type in alpha was nothing more than a common flu. I've only had out of 1,700 patients, about 4 patients with a pneumonia. 2 of them I got better because I didn't have access to things like ivermectin. Hydroxychloroquine was I wasn't quite aware of it. But I have a big interest in respiratory infections, and I think I'm a pretty fundy where asthma is concerned. The world's got it wrong on asthma, by the way, but that's a discussion for another time. I'm going to
Yes.
tell you how badly asthma. And I treated those 2 people with clarithromycin and and high dose steroid because I felt there was inflammation going on. Somehow,
Mm-hmm.
I had this hunch, and I treat empirically. I don't let people die. I mean, I give them what I've got. They 2 got better. One of them died at home. The other one went to hospital and died. But out of the 1,700, all of them got better. So I only had 4 out of 1,700. So at Philip, that's 99.9%. And I'm not going to take any accolades for that because the body is the best immune system, the best vaccine factory, as far as I'm concerned. Bill
Yeah.
Gates want to know, I will tell him the body is the best. I mean, you get a flu within 3 days. On the 4th day, I tell people, don't worry. Your vaccine factory is so good. We'll take 20 years to get an antibody for you, but your body produces in 4 days. You're good to go.
Yeah.
What I
So
was saying suddenly,
just
yeah,
to clarify a minute here, just to clarify a minute here. So
yeah,
when one of the most important things that I usually explain to people when I look at my presentations, looking at the courses, and you can tell me what your thoughts are on it. Without a shadow of a doubt, everything about COVID is viral autoimmune. The virus
correct.
triggers an
Absolutely.
autoimmune response, and any drug
Absolutely.
that is immune suppressive and immune modulatory is likely to be beneficial. And
Yeah,
in the picture of that, the most beneficial in terms of the acute phase will be steroids. Okay. Now, the
absolutely.
one question I'd like to challenge on that you said with regards to the early phase with the alpha and so on, because patients were still dying with severe disease, and when we looked at the autopsies, there was definitely significant inflammatory mechanisms that were not typical of ARDS, like a flu and so on. And
Yeah,
so I am sure that at that phase as well, there was still the autoimmune component. However, what I had said recently is that there are about 4 types where you have bronchitis, asymptomatic disease. Those are the milder ones. But you can have a viral pneumonia without having the autoimmune component with the microclotting. And so the viral
yeah.
pneumonia can be managed more conservatively. But once you have the inflammatory component with regards to microclots, you absolutely have to use steroids immediately in order to
Yeah.
get any better. Any thoughts on that?
Yeah, no, absolutely. To me, by the time I'd gotten to Delta, I'd read so profusely. I listened to a lot of your lectures. Thank you very much. You educated me. And whatever I succeeded in was thanks to guys like yourselves. And by July of 2021, I was ready for it. What I was seeing very suddenly, people would come to me and say, Doctor, I feel a little short of breath. I said, when did you get your infection? They would say, "Well, this was 2 days ago. I got my fever." And when I worked out this, I knew this is what COVID is for your viewers. It's basically viral, then it goes into the inflammatory stage, and concurrently, you must suspect the clotting phase. Don't wait for it to happen. You preempt it. We know the pathogenesis. So I said, hang on. If you're getting short of breath, this means one thing for me. By then, I'd known the Delta strain multiplies 70 to 100 times more than the Alpha strain. So, what that meant was that your body's immune response in your nose, in your IgA, was not sufficient to arrest the virus at the mucosal level and oropharyngeal level. So, it immediately ran down to your lungs. So, the minute you said short of breath, it meant to me there's lung involvement. I was not waiting for the textbook Atchison's crepitations. I then described a condition called early COVID pneumonia. It's never been described, and I'm hoping, Philip, that Rapiti will be recorded as the guy who described early COVID pneumonia. Atchison's book was written in the 19th century. We moved on. When there's lung pathology, you don't have to have crepitation. That is a policeman's diagnosis.
Can I
And
pause you there a minute on that? I think that
yes,
that is actually a very important point, because I remember when I was trying to understand the early pathophysiology with COVID. And one of the things that I remember seeing, I remember when I saw it and I was flabbergasted early in the pandemic. It was a guy who had fallen, he had a broken clavicle. He
yeah,
then had a chest x-ray for the clavicle. It wasn't a chest x-ray, it was a clavicular x-ray, but it showed part of the lungs. And you saw the pattern for COVID, and he had no symptoms. Now,
right.
this was a really important piece of the puzzle that didn't get investigated. What we call that inflammatory, viral inflammatory response that can sometimes only have mild symptoms. Okay. The question I would want to ask you is that because in some people that is mildly symptomatic, but the COVID pneumonia, as you describe, would you think that it is purely viral inflammation, or is it viral with some secondary bacterial infection? So I'm separating it from the microclotting component.
Yeah, well, I would say this it's an inflammatory process. Philip, I think if we can understand it, in a line, if I can show it to you, the
Yeah.
virus gets into your alveoli and the antibodies start attacking to get an autoimmune system. So if you get it in the early stage, you won't get crepitations. Remember
Mm,
that when the inflammation is taken, so when you get short of breath, it means your alveoli are getting damaged. So
mhm,
that to me is a start of inflammation. I did not, if I had to send somebody like that for an X-ray by the second day, it would show me nothing. It
mm.
takes you 5 to 6 days to
Yeah.
get this, and in fact, even hear crepitations. I didn't need to hear crepitations. If you go onto that slide, and I'll show you the list of symptoms I'd created and worked for me, and I'll run through them because that's going to be the future.
Yeah.
When they said I got slight shortness of breath, if I had a young guy saying shortness of breath on slight, then that was that, and you had cough. Why did you have cough? There's lung damage because you either have a cough in your throat, or you have a cough maybe coming from a bronchitis. You don't get a
Mhm.
wheezing. You don't get a wheezing. A cough
Yeah.
says there's something going wrong. Then you get shortness of breath on slight exertion. We need to understand that. When I go, I would ask them purposely, when you walk to the bathroom, yes, or if I change my bedding, or I'm showering. Now, you got to be very sharp at this. The other one was, I speak, doctor, and after a while, I'm out of breath. What does that tell you? There's severe lung damage. And the next thing is, I would ask them, tell me, how long have you been? Oh, it's just the last 2 days or last 3 days. Would you say that it's becoming progressive? And I call that declining effort tolerance. Well, I would say, tell me from yesterday. Would you say today you're more tired? Because people don't know how to articulate. So you got to literally put the words. Would you say today you're more tired than you were yesterday? Oh, yes, doctor. These were all adding up. And then I use something, the right peak flow meter. I'm big on asthma. As far as I'm concerned, any doctor who examines a lung and doesn't do a peak flow has not examined the lungs. Period. You fail any student who doesn't do a peak flow because your stethoscope is useless as it looks. And that to me is history and a peak flow. And if I had somebody that did not have asthma and a peak flow of 50% below expected, that clinched the diagnosis for me because I do asthma all the time. And yeah, you got somebody. What that was telling me, the lungs were the alveoli was so inflamed, so damaged, there was no air. So that helped me.
I
And
need to pause. I need to pause you here a minute because I think you've just said something that's really important. So I don't want it to get lost. You said something that you are absolutely right, and you've clicked my brain using the peak flow meter. Okay.
yeah,
Now, as just for people to understand, is that when people have asthma and they try
yeah,
and blow out, because there's inflammation in the airways, they can't get the air out very quickly. and in a very strong way. So the peak flow number is significantly lower. But you're right,
Yeah,
that's primarily in asthma. So now let's just think this out a minute. So when you noticed that significant difference in peak flow in the COVID patients who had no asthma,
yeah.
they didn't have a wheeze.
No,
What was the mechanism? Was it just a bronchitis? But even then, they should get
no.
a wheeze. What was the mechanism for that?
Well, the thing is, it's quite obvious. All the alveoli was damaged. It was inflamed. There's no air going in, no air going in, no air coming out. They didn't have the capacity to push it out because there was no wheeze. And I can tell you, by the way, you don't get a wheeze even in asthma with a peak flow of 50 and 20, 200. A lot of people say they outgrow asthma. I've challenged so many experts on asthma to say, give me I'll send you an article I wrote 35 years ago. One of the classical signs of asthma is a hoarse voice without any explanation. I've had a nursing matron who's been to three major teaching hospitals. And I said, but why is your voice hoarse? She said, I don't know. I said, well, let me give you do a peak flow, give it a puff of the pump. Her voice immediately changed. And 1 month later, Philip, she came in with a CD saying, Doctor, I cut in a gospel CD. But
Mm.
nobody's listening to me, and I'm fed up with that.
Yeah,
I'm
no,
the expert.
I'm
No,
listening.
really.
I'm listening to you. Don't worry,
Yeah.
Robert. I'm listening. Okay, so let's get back to
So,
the
so,
symptoms.
so,
Yeah.
so when we come to this point, I called it early COVID pneumonia for the reason pneumonia was usually, as we were taught, crepitations. I would listen to the lungs, no crepitations, and I was satisfied. You had the fever. Now you got shortness of breath. You got lung pathology. The only lung pathology is a pneumonia. You're going to get high dose steroids, and we'll talk about my protocols. I didn't
Mm,
wait. When I started by day 3, day 2, Philip, by day 6, these people said, Doctor, I'm so well, I'm going to work on the 7th day. The world ought to know we lost so much of money, we treated too late. You know, the dictum in medicine is treat early, don't wait, don't wait. And
yeah.
that's what I did.
So can I
I didn't, no x
can
rays, no
yeah.
scans, no PCR tests. I didn't need that. I treated, empirically. I'm a clinician.
Mm.
My people couldn't afford money. I work in a very poor community. Would you believe if I told you the cost of my treatment was cheaper than the cost of a PCR test? Almost 80% came to me by the first visit. Every one of them had my cell phone. I had 4,000 WhatsApp numbers because I knew the press was after me. I know the academics were after me because by then they heard about me because I was taking patients from teaching hospitals, Philip. I was getting them better and I never turned patients. I said, I will work like a dog, but I'll see to it that everybody gets better. And I was 72. God knows where I got that strength, but I did it.
Yeah.
People,
So
yeah, I work
let me just
17 hours a day.
tease out
Yeah,
something here. Okay. I remember when I first interviewed Dr. Chetty, and he explained about the eighth day. Okay. Now I know you have,
yeah,
so don't worry, just work with me here a second. There's a reason why. One of the things that was very characteristic about COVID was the delay between the onset of symptoms and the shortness of breath. And
yeah,
when the shortness of breath came on, it came on pretty quick. Okay.
yeah,
So, what I realized was that when I listened to what Dr. Shetty was talking about, is that the first thing that you had to realize is because the virus evades interferon so well, in the very first few days of being infected, most people have absolutely no symptoms.
yeah,
So
yeah,
then, by the time they get the first symptom, and this is now Dr. Shetty was noticing, so he would notice that they would have just minor symptoms. They'd have like a little tickly throat or maybe a little bit of a cough, a temperature, feeling a little bit achy. That was the very first symptom. What he was noticing was that the shortness of breath that you are describing here would happen most consistently about 8 days after that very initial minor symptom. So, this is why I differentiate, because what you're talking about, the shortness of breath, once you reach shortness of breath, you know that that person has either a full blown viral pneumonia with secondary bacterial infection, or they have got the microclotting. And that, because it's autoimmune, is theoretically about day 11 from the point that they had been exposed to the virus, if that makes any sense. So I was just trying to, what are your thoughts on that?
If you don't mind, I completely disagree with that because I'll
Yes,
tell
yes,
you
yes,
what.
I don't
I'll,
mind.
I'll tell you what. What's happening is that this virus multiplied so fast, it went straight into your alveoli in the ACE2 receptors and bang on your antibodies stuck onto it and damaged the alveoli. So for me, the minute you had shortness of breath, and I disagree with Dr. Chitney, I told him, if you're going to
Hmm.
wait day 8, and I'll tell you, Philip, if patients came to me by day 4 with a shortness of breath, it prolonged their illness of response by 1 week. And I'm very
Oh no, no,
categorical
I
about it.
know. Yeah, so just to clarify, 'cause I know Dr. Shetty isn't here to say his piece. So I would say
We
no.
saw
The
different things.
minute he said, the minute you are short of breath. So
You got
this is once there is shortness of breath. Actually,
yeah,
he went even further. He said that even if their symptoms were just fatigue, not even
yeah.
with any breathing difficulties, the minute it changed, he would treat. He wouldn't wait. And so, in that sense, you're both about on the same, which is very early to get immunosuppression in to try and therefore prevent the progression of the condition. So, when you were doing your steps and when people
Yeah.
were calling you, how would you know from your point when was the right time to get straight in?
As soon as there was shortness of breath, as soon as there was lung pathology, and I gave you the list of things: shortness of breath, declining effort tolerance, and shortness of breath on slight exertion, and these were fit people, and
And so
and
it was
um,
any one of
and
them,
the
or
yeah.
all? Did it have to be, say, did it have to be five, or could it just be one?
No, anything. If it was short,
Anything.
anything. Because what's the next step after your fever? Is shortness of breath, and
Hmm.
anything dealing with lungs is shortness of breath. I was not gonna. For me, it was a case of do or die because the
Yes.
drugs I was using were safe, innocuous, so I would lose nothing. The only reason I used the antibiotics and I used clarithromycin and it worked well. Was it was a bit antiviral because in case there was any more virus around lurking somewhere, and secondly, from the Spanish flu, you recall people didn't die because of the virus. I think you made that very moot point. People don't die of the virus; they die because of the effect of the body on the virus. And so, with the Spanish flu, it was bacterial pneumonia. If the Spanish flu broke out today, we'd have had enough antibiotics to declare it not a pneumonia. So I was being preemptive. I hadn't had time. So I treated, prophylactically, should there be due to mucus release, it becomes a nidus for infection. So I didn't want to take chances. So I gave them a package of things. And I work on a basis. I'm more a toxicologist. You don't know the other side of me. I'm very into addiction medicine and on the street stuff and the over the counter and doctors over prescription. So I tend to use a combination of drugs of the similar type of class for the reason that if you use different drugs doing the same thing, you use less of it and you have less of. For example, I would combine a steroid with colchicine. So I'll be
Hmm.
getting an inflammatory effect without needing high doses. I also use an SSRI because it worked as an anti inflammatory, particularly for the elderly. You didn't want to use too high doses of steroids with them. And we'll
Hmm.
talk about the elderly and how I treated them. And the point about oxygen, if I, well, so we've come to that point where was any inclination that there was a lung pathology. I went in straight with my steroids. I didn't play. I've been dealing with asthma. I would deal with maybe give people 40 milligrams of 50. But here we were dealing with alveoli pathology. And that was the size of two tennis courts. So people, I saw my colleagues were giving 40 and 50. I was banging them with 100 milligrams, 50
Yeah, no.
twice a day.
No, this is an important point. I have to pause you here. And actually, I'm going to have to do a whole presentation on this
Yeah.
Because, as I explain to people, is that when you consider what was happening, and this is why I was so sad that the autoimmune aspect of COVID was lost in the context of the
Absolutely.
experts, because
Yeah.
any expert knows that if you have an autoimmune disease, say SLE,
Yeah.
rheumatoid arthritis, doesn't matter which one, if
Yes.
they have that and they have lung involvement to the extent that they are short of breath, you you were talking about 100 milligrams of steroids. When I asked the rheumatologist and I said, listen, if this is a good going lung vasculitis, he says, no, we will use a gram, 1000 milligrams of methylpred with cyclophosphamide to absolutely shut it down. That's how you treat a
Yeah.
lung autoimmune. So you're absolutely right. And the fact that one of the saddest things, and I can't cover it all here, was that when they identified that dexamethasone was beneficial, why didn't they check the doses? What made
Yeah.
you know that and nobody else? What made you not stick with the 6 milligrams of dexamethasone?
Well, you see, very early in my studies, I knew about the surface area of the bronchi. And I said, but we're not dealing with the bronchi here. It's got nothing. It's just a conduit to the airways. And there's a lot more I'm going to tell you about what I discovered that's not mentioned anywhere by any of the experts. So I really feel I'm the expert they ought to be listening to. I never relied, Philip, on the oximeter. If I had somebody with a 95% oxygen and he was short of breath, I discarded that oximeter reading because I don't treat machines, I treat people. If you came in panting and you had 95%, I had oxygen in my rooms. And I was so let down by the oxygen companies. They closed on weekends. And I want to expose these buggers because we were in a time of crisis and I wanted help. There was a crockery company who were doing some humanitarian work, had 70 machines at my disposal. And I was the only guy in Cape Town with 5 million people that was using up all their 70 machines they were doing. The big banks could have come up with 8,000 rands. In your currency, it would be about 400 pounds. With a machine, I could have saved thousands of more people. And if you had met me earlier, we could have done something combined to save a lot more people in the world. They wouldn't have had to die. But, I just didn't have the platform. So, I mean, coming back to, why we need to use oxygen, I think, are we done with that? No, from early COVID pneumonia was when you didn't have crepitations. I made the differentiation. And when I listened to them by day 4 on Delta, all of them had crepitations. And you had to have a keen ear. Most of them were in the posterior right or left lung bases. And if I listened to any adventitious sound, I didn't wait for the textbook type of crackles. It was adventitious. I said, this is pneumonia. And believe me, Philip, you waited one day. You added 1 week to treatment. And you
Wow.
waited, and you waited 3 weeks. Then you dropped down to 35%. That's how rapid the oxygen was falling. And I had oxygen, and we can talk about. So the difference without crepitations, all the signs I mentioned was my definition of an early COVID pneumonia. That's Rapiti signs. Put it in the textbooks because you don't need to hear crepitations to know there's lung damage. If you got
Mhm.
the symptoms, and if you're going to wait, X-rays only pick it up 10 days later. So these doctors were sending them, that's a day gone.
Mm.
I would see them in 3 minutes, make the diagnosis, have my treatment ready, off you gone. And I would be in touch. I would tell family members, I made them nurses. I said, you send me the oxygen reading. I would need to know what's going on. And my staff my wife was part of my team. And they would tell me, Doc, this is what's going on. So I had to, manage. My rooms became the COVID center of Cape Town. I
Yeah.
had
So
people
listen,
coming.
listen, curious
Yeah.
question here. When it comes to managing people on the telephone, so I can understand you have a patient there, you listen to them, they're a bit short of breath. The minute you hear anything on their chest, boom, this needs to be treated aggressively. Okay. When you are dealing with people on the telephone, And so
Yeah.
you couldn't examine them. You didn't have a peak flow meter. You didn't have oxygen saturations. How did you do that clinically? How did you do that from the history?
There's the signs: shortness of breath, cough, declining effort tolerance, um, shortness of breath when speaking. I had fever symptoms. What else was raining at the time? Whatever I'm going to give you is not going to kill you. But if I save you, I've erred on the right side. So I
Mm.
just went on that. And Philip, I was treating at least 5 people at night. I worked from 8 till 7 in the evening, seeing about 40 patients in my rooms. They would come, my rooms were full, the road was full. It was like a circus there. People were just gathering. And I just took it in my stride. It was difficult. I'd come home 7 o'clock, 8 o'clock at night. I'd take my calls because people would book from Australia, New Zealand, you name it, the UK, and from US. They'd see my videos on Facebook when they did allow me, and I would sit down, take their history, and tell them what to get. They would get the treatment, and we'd be keeping in touch on WhatsApp. Was a great help to me because
Yes,
through that, because I didn't need to see them, because
yes,
once I had them on the right treatment. I mean, I had a range of treatments. I had a smorgasbord of treatments.
yeah.
I
So we're
mean,
going
we
to come
came,
to the treatments in a minute, but
yeah,
I'm curious about something.
yeah.
When you decided to go and start examining the patients, okay? Because at the time, the recommendation was for the patients to stay at home. You had to protect the doctors as well from getting exposed. Why weren't you afraid?
I didn't buy that narrative because I felt as a doctor for 45 years, I've always known that we get subclinical infections and we get immune to it. If I've got an immunity to it, I can't get infected. There's no way I'm going to get another infection. I, I, I was prepared to die in my rooms because I felt this is a cop out method. As a family physician, I touch patients because that's what people want. During the alpha strain, I examined them. They said, "Doctor, I feel so good. My doctor doesn't want to see me. He doesn't want to touch me. I feel so disappointed. I've known him for 20 years. They put the phone down on you." And I said, "No." And I became confident when I started reading The Masks Don't Damn Well Work. When people would come to me with a pneumonia, Philip, this is what and I can say this today because I'm sitting here alive. I'm 75 going on to 76, and I've reversed my age. At another time, I'll tell you how I did it because I was taught wrong in medical school. You know, I found that I was coping well, and I took my own prophylaxis. By the way, we're not going to talk about what it is
Okay.
because I can't sit at home and not do anything and know my patient's dying. I felt I'd be letting them down. I went, and nothing was happening to me. Breathless, almost keeling over with the mask. I said, "Take that rubbish off your mouth." "No, doctor, I don't want to infect you." I said, "Bring it on, pal. I need the booster because every time I got natural immunity. When I get the infection, I'm getting a booster. Fauci doesn't know what's boosting. You don't give these things, you get another virus. And I know I had good natural immunity. I've only had COVID about 3 times. They were mild. And I've gotten better. And I was so glad for it. And I had my treatment for it. I had an antiviral and it worked. And I'm still alive now. I'm doing well. So
So
I
so
examined them.
it
Yeah.
raises some important points, you know. Robert, you have to realize that part of the reason I think, and I'm going to pull you into the situation, say with Dr. Shetty now. So Dr. Shetty, he went and he tried to tell people, similar as yourself, look, I'm trying to help people here. Whilst you may not agree, somebody may not agree, I can tell you from clinical experience, none of my patients are dying. Okay.
Yeah.
And he's trying to share that and he's trying to bring that across to the world. And instead of people listening, he then gets not just censored, but he is they're currently trying to take away his license to
Yeah.
practice.
Oh.
What do you make of that?
I think medicine's gone wrong. I'm an old guy now. I'm disgusted with medicine. I mean, the thing is, I want to see the return of the doctor's individuality and his independence. And I think there's a lot of big cartels involved in this. And I want to see that doctors have the right to treat their patients in the best way that they know, and they will take the risk for anything they do wrong. There should be no interference from government, no regulatory authorities, as long as you can argue. You see, medicine, I'm sorry, is a second army. The only difference is that the army wears brown coats and the medicine army wears white coats. What the boss says you must do. And I'm a rebel. I'm a thinker. I will listen to a professor, but if he doesn't make sense, I'm sorry, I'm not going to do what you tell me to do. Because there are a lot of things they've said. So I think it's a disappointment if Dr. Chetty goes, because he's a critical thinker. I have the greatest respect for him, not for many of my colleagues. I can understand people who had a conflict of interest and were captured. But we GPs, we independent GPs, we were not captured. And I mean, I showed the evidence. They saw my videos. A lot of doctors learned from me, and I'm glad for that. But they should be standing up. We need some guts. I think I, more than Chetty, stuck my neck out because I was prepared to die. Because I was prepared to. I mean, I'm an activist. I mean, an activist in a sense. I was opposed to all forms of injustice. I fought for against apartheid in South Africa, especially on health. I felt there must be some dignity, some humanity, everybody. So this was another fight for me, and I was prepared to die for it, because I think it is wrong to see our patients die when we are there standing by and doing nothing about it. So I hope that whoever is trying to get Dr. Chetty off the books will have a change of heart, because there's no question in my mind, are absolutely wrong. And I'm prepared to debate with them. And I have debated with some of these professors and made them look like ruddy fools. And because it's not their degrees. I have got no respect for their degrees other than for their morality and the integrity and their knowledge. I'm afraid a lot of them are textbook guys. They don't understand the science. So my take is that I hope Dr. Chetty is not struck off, because he's a great doctor and he's the kind of thinker we want. He
Yeah,
fought,
absolutely.
no, absolutely.
So
I'm the same. Take me away, because I'm a thinker as well.
yeah. So
That's
taking now. So I mean, I can understand exactly what you're doing. I can see why it was working. I can see the benefit of it. Now, let's just pause a minute here. And we are now jumping forward 2.5, 3 years to the present day. We're dealing with a different kind of beast here. Okay. Omicron is not the same as Delta. It
no,
infects different parts of the airway. It replicates in a different way, but it will still be lethal in a different way. What are your thoughts about where we are with Omicron, the Omicron variant? And is it actually an issue in South Africa
no,
as it
not
is?
really.
Yes.
No, not really. I will show you there is a difference, and this is why it's so important. When people call themselves experts working in laboratories as virologists and immunologists, they got the wrong thing. That doesn't save people's lives. Chetty and I and you, we see the patient. On October 15th, Delta came to a dead end. I saw nobody with Delta. And suddenly, I was seeing people with a mild flu, and that was Omicron 1 and 2. When I saw about 1,100 patients in that 2.5 months, I only saw about 143 in the next 2 months, and he died away. It was very mild. I only saw about 10 people with pneumonia, one with gastroenteritis. All got better without me doing much heroics. I just put them on a bit of oxygen. They did not need supplemental oxygen. And I think at some point we must go back to why I used supplemental oxygen and people with comorbid disease. But I've got some of the patients that I'd like to talk about, how I brought them to life and how they're still doing. So when we went to Omicron 4 and 5, what was happening? There was a different situation. They were all of them were coming with only a cough. And so what they did was typical of what all our patients do. They use a rubbish thing that we call cough medicines. I've stopped using cough medicines for the last 25 years, Philip, because you don't treat a cough by treating the symptom. You treat the cause. So what they were doing, drinking 3 bottles of different types of the same type of cough medicine, different names, thinking one was better than when they'd come to me. I had a 92-year-old lady. I want you to show that picture at some point. She came to me and said, "Oh, doctor, I feel a little lightheaded. I think there's something wrong with my blood pressure." And she's a dear old lady. And I said, "Okay, ma'am." The ambulance came around to her house. She said, "No, I'm not going to any hospital. I'm going to see Dr. Rapiti in the morning. If I'm going to die, I will die." She came to me. I put my stethoscope on the back of her lungs. She had extensive pneumonia. I said, "Wow, you've got extensive pneumonia, Granny. That's the one."
Mm.
She had she had extensive pneumonia. The point I'm making is Delta worked slightly differently. It was extremely virulent. If you had even 80% pneumonia, you were extremely sick. Here was this lady with extensive pneumonia on clinical examination. She had a 95%. So all I did was I didn't play with the elderly. I treated her as I would normally treat a pneumonia, and I used high dose steroids. I didn't play because I thought it was life and death here. And I didn't think 10 days of steroids, high dose, is going to knock their bones. So I put her on treatment and I got supplemental oxygen. And I think, if I may, I just want to labor the point about supplemental oxygen. I don't know how Dr. Chetty managed it. My point was this: I was not going to allow anybody to get hypoxic, especially towards the brain, because we cannot predict what damage hypoxia is going to do to the brain. Because medicine, good treatment is not about getting you better today. It's about getting you better today so that you live well in 10 years' time. I don't want to get this lady better and I find that she's got dementia, or for you that matter. So I treated every aspect. That is why when you said there cannot be one expert, one lung guy. I'm a general practitioner. I look at you holistically. I look at you futuristically. What am I doing to make sure that you stay well? Well, Philip, 2 years down the line, I met this old lady. She's looking well, man. And she had 95% extensive pneumonia, put on high dose drugs, no broken bones.
Mm.
So
Yeah,
my
so
point
this
is,
is this is one thing that a lot of people were afraid of, and it's important to talk to it because just for the audience is that if you ask a clinician about using high dose steroids, they are very worried about if the person is diabetic, is it going to damage their bones, is it
oh,
going to cause psychosis? These are all the side effects that can happen with high dose steroids. And so, why weren't you afraid? Why weren't you
well,
worried?
well, the thing is, yeah, there was two choices. It was quite simple. COVID was very simple. I'm starting to lose respect for my doctor friends' logic and intelligence. You got a situation, people are going to either die or live. If I gave them a bit of side effects that I can treat, so what the hell? I've had a nursing sister of 79. I sent you the clip. If you can play it, you'll hear what I didn't even see this lady. I treated people on with diabetes on the phone because I was forced to. What I did was I said to them, "You diabetic, this is what's going to happen. I'm going to give you high dose steroid. Your sugar's going to go up. So what I want you to do is you're going to get a pen of Actrapid, and insulin, shorter acting insulin. I would teach them how to use it. I would control the sugar with an insulin." And I taught this particular lady, a mother was 69. Was it no 79? 79. Could not walk. She was in bed and we battled with her. She couldn't even come to my rooms, and I couldn't. There was nothing I could do going to her. I would teach the daughter how to deal with this. She would give me the oxygen readings. She was on oxygen, and the sugar was going up. I told her, "Go get yourself a pen of insulin." She said, "Now, doctor, how do I use it?" I said, "Get me onto video on WhatsApp." I said, "Now take your vial out." I said, "Turn the thing off. Now start giving them 5 units. Test the sugar for me. And if it's still up, we'll add another 5." So we did it gradedly. So, Philip, I was accessible, available, accountable, and affable. That's what a good doctor is. The 4 A's. If you're not that, don't do medicine. Please go and cut the grass because don't waste your time. No, really.
Wow, yes, that's brilliant, Robert. Yes, so you're quite right. And so this is something that's important in that what people don't understand, yes, there are risks with high dose steroids, but what you're demonstrating there is you acknowledge the risk, you look at the risk benefit ratio, and you try and mitigate the issues like the blood
You
sugar going out of control, and you manage it.
Yeah, it was manageable. What are they talking about? Diabetes. I've been treating
Mhm.
diabetes for 40 years. I never send them to an endocrinologist. It's a bit of a joke. I mean, I've managed them. None of them end up with coma. Nobody in my practice ended up with a coma because
Mhm.
I self empower my patients. Another thing I do, we do a participation way of treatment. And I was so pleased the patient told me today, Doc, what I like about you, you don't force anything. You give us the facts, you say, right, what would you like me to do? And they feel good. I mean, I'm very good at getting people to follow lifestyle. When doctors say, oh, patients don't, I guess I'm a motivational speaker. You'll get to know that by now.
Yeah, yeah, yeah.
I, I'm a salesman. I get them. I said, Mama, look at me. Do you want to die looking old and sick? You got no children to look after you. Don't go to the old age homes. Die like me, healthy and hale, and go to your grave and say goodbye, everybody. That's how we should be dying. and and and,
Absolutely.
they, and they're willing to follow uh, my eating plan. People talk about eating plans, and that I also did. And I said, don't worry about eating because starvation is kind of good. It kills the bad cells, so they don't get worried about it. So I've had, this lady that I'm told you about, which treated over the phone. She's 81 now. This lady walks up ladders to pick up things from the cupboards. So
Mm,
in my practice, this is what I'm going to diss now. The comorbidities didn't matter, age didn't matter, obesity didn't matter. It's bull dust.
mm,
You had to treat. I had a young lady of 27. She was brought in by four burly men because she was so overweight. She had an oxygen of 45%. I was about to close practice. I never shut my doors. I said, do you want to go to hospital? Because I know the academics were after my guts. She said, no, doctor. She just waved her hand. I said, fine. I took on the challenge. Within 2 weeks, she came back walking in overweight, 45% with my treatment, and I got it better. So this crap about, oh, she's overweight, she's at risk, is a lot of rubbish. You don't know how to treat patients. I
yeah.
think doctors at that time were very discriminatory, you know, and I
So
must say,
it raises the question, because you have to realize now, Robert, is that the public are having an issue at the moment. So many
yeah,
of the things that they have been told is scientific and is correct are falling apart. Okay?
oh,
The whole
absolutely.
narrative is falling apart. And for many people, and because I look at my comments in my YouTube posts and so on, I see what people are thinking. And a
Yeah.
lot of people have lost faith with science and with medicine. And the implications of that are quite serious because, yeah, there were errors around COVID, but it doesn't mean that your respiratory doctor is no longer good. It's that kind of problem.
Well,
Now, how 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 does is this handled? It's so putting it to you now here because us talking about this here now is highlighting even more the failures of the system. Are
absolutely.
we contributing to dismantling trust in the system by actually talking about the failures? Is that the right thing to do?
Yeah, I think so. I think we must be honest with ourselves because they got it wrong. Whoever decided on the treatment of COVID didn't understand COVID. They started getting oxygen machines and separate rooms. It was a lot of rubbish because I explained to a respirologist, a pulmonologist, because I'm a thinker. I said, Guy, why are you using high flow oxygen? You've got damaged lungs. Pal, what you're doing is that the function of the airways, that is the alveoli, it's a membrane. It's got to transport that oxygen. How on earth are you going to take high flow oxygen and transport it through damaged lungs? You're going to blow it up and you're going to get a pneumothorax and they're going to die. And by God, what happened. 99% that were on ventilators died. Whereas what you and I were doing, we were treating that lung and I was giving supplemental oxygen. So, which means that the lungs was improving and healing slowly and it wasn't being under pressure. And with that continuous oxygen, they were getting better. I mean, I had
Mm.
people with 35%. So that they got it wrong in the first place. You did not need ventilators. And I agree with Professor Robert Clancy. COVID should have been handled by GPs. And I would have given them the protocol, and this would have been a piece of cake. Nobody landed in a hospital. Just for your information, your viewers' information, they sent everybody into hospital. Oh, you got sick. You come into hospital. What were you giving them? Oxygen. Oxygen wasn't the treatment. You needed to use all the other things. I used a lot of clotting agents, blood clotting agents, by the way. We didn't talk about that. But in
Mm.
that study done by Professor Kunti, there was 430,000. One third of those people that were admitted in the UK and in Spain returned to hospital with autoimmune disease, and another one third died because of their bad treatment. I can tell you, in the 3,000 that I treated, not one had long COVID. I think that's a lot of bollocks, because if you treated COVID early, you kill them. What they talking about long COVID is really the spike protein that's never leaving your body because of the pseudoephedrine molecule that's in the spike. That's mean detected for over 60 days, and because of lipid nanoparticle, I don't, if you're aware that the Pfizer protein has got 37 million nanoparticles, and we've got 40 million cells in our body, a trillion cells in our body. So there's enough nanoparticle to destroy every cell. So that's being called long COVID. And I think it's unfair to good old coronavirus. It wasn't the
Yeah.
coronavirus that did
Uh,
that. It's the
Well,
vaccine.
on that point, yes, we'd have to disagree because I
Yeah.
have been battling with this long COVID research for oof, 2.25 years. I thought it was going to be easy, but what I realized, so I'll tell you what it is. When we've heard about these nebulous conditions, the post-viral stuff, the MECFS, the fibromyalgia, which truthfully the scientific community has ignored for the past 30 or 40 years. This is on the same spectrum. So suddenly now we have 30 or 40 years of research to figure out what in the world is going on, because some of these patients are really, and it can happen. I agree with you that it can happen from vaccination, but without a shadow of a doubt, infection alone in the susceptible population can certainly trigger it off. But yes, that's a.
Let me comment on that. I'll tell you what the problem is. In the UK, US, and all the so called advanced countries, they weren't treating early. In Africa, South America, and in Asia, we were using ivermectin, and you're killing that virus. And if you kill that virus, and the virus doesn't last in your body for more than 20 days, Philip, and it
Hmm,
hasn't got a lipid nanoparticle to take it everywhere. So I'm not seeing a single, because right now, Philip, I'm the go to guy in Cape Town. If you got anything wrong with COVID, people are finding me somewhere from the. I work in a very poor community, but I have had the richest of the rich coming to my rooms, eating humble pie. And to me, I don't differentiate between patients. It doesn't matter about your social status, because for me, COVID became a calling. I'm not trying to blow my trumpet here. If you didn't have the money, it was not a reason for me not to treat you. I'd rather do away with the money than to know that somebody couldn't afford me and lost their lives. And
hmm,
I think
yeah.
that is where I want to see medicine return, where the doctor has full authority to decide, I will not charge. In America, if you don't charge, you get fired. I don't want businesses to be in charge of my healthcare anymore. I'm sick of them. Through your program, I want to say this: businessmen, get out of my life, because this is a beautiful profession. I've enjoyed it. I want nobody telling me how to treat a patient. So, I've done that, and I've treated, some of them had. I've had one guy who's had, it took me about 3 or 4 months to get him better, Philip. But he's got no long COVID really. He's got emphysema. So
Hmm.
if there was long COVID, he should have had it, because the virus gets, you know. And
Yeah,
I must tell you, I must tell you, for another patient,
yeah.
he went into a hospital. This is what was happening. You'll have to translate the amount in money. They took about 500,000 rands in the hospital with this guy, and 500,000 rands, about 25,000 pounds in UK money. It was a lot of money, and they discharged him when his money dried up. And he lived down the street from me. And his wife came to me and said, Doc, I heard you treating COVID. Tony's at home. I don't know what to do. He's got an oxygen tank and they left him. I said, you're on there, baby. I'm going to treat him because I wanted to take challenges. And I treated Tony for 3 months. And you got a slide of Tony. And he was thin as a scarecrow, on the verge of dying. This is a guy who also had a throat cancer. And I treated him for almost 4 months. From 60%, Philip, he gave up his oxygen tank.
Is this
Tony in four
Tony?
months. That's right. The hospital discharged him, as you can see. That's how he was lying, and I took him over. And Tony, on his 65th birthday, was celebrating. It was 2 years, about a year or two later. He did so well because the hospital was sending him to rest in peace after 30,000. Tony has done so well that he's driving his own car and driving his family up the pole. And I'm wondering whether I did him any good, the family any good, because the point is these pulmonologists, infectious disease specialists were too proud. When Tony went back, they picked him up on the new year when he had new benefits and they wanted to see him. Tony said, why do you want to see me now? You wasted my bloody money. It was Dr. Rapiti who saved me. Go and stuff yourself. Good for him. But the infectious disease specialist didn't come and ask me, how did I treat it? The other thing I need to mention is that I paid particular attention, like you said, to the clotting factors. I did a routine D-dimer. It was expensive. The labs were ruthless in this country. They didn't have any decency in lowering the price. If one thing the government could have done is allowed us to get this facility. I did a D-dimer, and it's important to know. You might do a D-dimer initially and it will be low. Don't be fooled by it. You do it. I repeated it on this one particular nursing sister, and it went up. I put on, and I had my protocol there. I would use aspirin, and if it was a certain level, I'd go up to clopidogrel, and then I would go up to the Noakes. And the one patient I had, he was 71 years old, COPD, had a heart problem, and he had a D-dimer of 11,000. I don't know what's the readings in your country, but the normal reading was 500. This gentleman took me also 3 months to get him better. I haven't seen him once, Philip. He lived 50 k's away from me. His
So
daughter, yeah,
yes. So
she said he was.
I want to show something here. I'm going to just flash it up because some of the stuff on it we can't talk about. Okay. So I'm just
Yeah,
preparing the audience for this. So you can look at it, but I'll ask him very specific questions about it. So
yeah,
as you said, this is a toolbox that you had,
yeah,
and it had
yeah,
lots of stuff in it, including things that rhyme with pectin.
yeah, yeah.
And so on.
Okay.
Now, there are a couple of things. There's one thing really that stood out to me in your toolbox, and I wanted to ask you specifically about how you use. So tell me, Robert,
Yeah.
as we close out now, what is it that you think, based on your experience? And because, as I said, in South Africa, COVID seems to be over because
Oh,
they've
absolutely.
probably
We've got a flu
herd
now. Yeah,
immunity. So they
yeah,
have herd immunity. But I can tell you that in other parts of the world that are highly vaccinated, they are still having circulating Omicron variants. And the presentations are extremely unusual. They're not presenting with lung disease and so on. So,
yeah.
based on your experience, then it suggests that people just need to get in the trenches, observe the patterns of disease, and try and understand exactly how it's affecting patients. Any advice to the medical communities?
Well, look, for me, by and large, Philip, I would still think that coronavirus has the pattern of, viral pneumonia and hematology and clotting. And I've given my early signs, and I would think if it's a rapidly multiplying virus, like you would have found with the Omicron, it was extremely infectious, but not so virulent. It's you treat the symptoms as they present. I don't think we need to be pedantic, and each one is individualized. And I think why you're seeing so much of it in the other countries, I think because of immunodeficiency, and we need to come to that reality. And I think sooner we wake up to the reality that when you have an infection, a vaccine is not going to save you. I mean, that's XYZ, for heaven's sake. I mean, whatever platform we are in, you've got to use an antiviral. It's better time we come to the party and start saying there is a drug what one can access, use, and treat. But the unmentionable drugs are the ones you must get. It's up to
Absolutely.
you.
And just as
It's up to,
a final
yeah, look,
reminder to the audience, take a look and remind yourself without us saying anything on it. But yes, that's his toolbox that he has used and used very successfully over the years. And what I can say, Robert, is that we appreciate you sharing this kind of information with us. We appreciate you raising your voice. And you did lose your voice at some point with regards to censorship in the past. But the point is that it's only when science can be adequately debated and discussed and challenged that we have an evolution and a growth of science. So thank
well,
you very, very much, Robert. I really appreciate you being here. I'm sure we're going to be in contact with some
I would love
um,
to. Yes. Yeah,
other
because you are.
presentations.
Yeah, no, you're the clinician I'd like to talk to because I'm sorry, I get a little tired of journalists. They don't understand what I'm talking about. And it's so good to talk to a colleague, and I have the utmost respect for you. I learned a lot from your lectures. You're a terrific presenter. I love your lectures. Thank you so much. And for giving me this opportunity. And for your viewers, if they want to know the information they can't get on mainstream, they must go to my Telegram page. It's Dr. Rapiti, and if they get me on WhatsApp and they want to get information, I'm very happy to oblige them, because nobody should be. I'm trying, like you're trying, to reinstate the role of doctors in society. We've lost it. And thank you
Wonderful.
very much, Philip. It was so nice chatting to you.
Wonderful. Have a great evening. Just stay with me until after the outro. Thank you,
Okay.
audience, and we look forward to talking again in the future.